So thank you, Lynn. Before I get started, I wanted to make sure that you were focused on what I was saying and not on my eye, which I had a spontaneous subconjunctival hemorrhage yesterday after swimming. It's uncomfortable but not painful and unsightly. And those of you who would like a more titillating explanation of how this happened, please speak to my consigliere, Eduardo Sanchez. Our task is to address pathways to obesity prevention in primary care. This could be a very short talk because there's very little known. As Ray said, there are very few scalable, equitable, and culturally sensitive primary prevention interventions directed at minority populations. The APOP report focused on three major issues. Standardized care, these are paraphrased, standardized care and advocacy for healthy community environments, coverage for obesity prevention and care, and encouraging healthy pregnancy, weight gain, and promoting breastfeeding-friendly environments. So my talk will cover these, although not necessarily explicitly. What's interesting and what hasn't been raised here is the fact that we have much more effective public health strategies than we do clinical strategies for obesity, and that applies to both primary and tertiary care. In addition, another theme that the whole issue of care brings out is that obesity and obese individuals are themselves underserved groups, that our clinical strategies have lagged well behind the public health strategies. The importance of this is that although we're seeing a plateau in girls and women, we're seeing a continuing increase in boys and men in the prevalence of obesity. Much of that, particularly in boys, is driven by African American boys. The other thing that hasn't been put on the table, and I recently became much more sensitive to this than I had been previously, is that the prevalence of severe obesity across the board continues to increase. And this is in and of itself a public health problem. So that, for example, you can see here in African American girls and boys, there's a very substantial prevalence of severe obesity, defined here as a body mass index greater than or equal to 120% of the 95th percentile, which is probably the most useful clinical definition. About 9% of African American boys, about 12+% of African American girls have severe obesity as designated by this measure. We're also seeing a continuing increase in the prevalence of severe obesity in the adult population. This is not advancing. So you can see here that the disparity that we began to see among African American girls in the last slide is even more accentuated among African American women. About 18% of African American women have severe obesity, defined as a body mass index greater than or equal to 40. The issue of prevention in adults is almost a moot point because only about 35%, 30 to 35% of adults are of a healthy weight. So clinical approaches are really an essential way to approach this problem. And Ray did a wonderful job of stressing the importance of the public health approach and the kind of broad reach that will have. But that's not going to achieve the caloric deficit necessary for the severely obese individuals to lose weight. For that, we require much more aggressive clinical therapies. Next slide, please. The chronic care model provides a nice model of how the medical systems need to interact with environmental systems around obesity prevention and care. And there has been some early work now in changing the delivery system design and self-management support to address a problem that is as prevalent as severe obesity in general and severe obesity in this case. There have recently been, next slide please, there have recently been about 5 papers that have provided what I would consider the first attempts at innovative care for obesity, beginning with group sessions of parents of overweight preschoolers done in a primary care setting by Quatrin, who's the chair of Pediatrics in Buffalo. one of the interesting observations in this paper was that the change in the child's weight also predicted the change in parental weight. And the parents in this study lost 2 BMI units, which is a pretty extraordinary weight loss given the modest engagement that they had. Another observation that's common to all of these studies is that the care was delivered by care extenders. Now, none of the papers were very specific about who those care extenders were. Some of them were probably nutritionists, some of them were nurse practitioners, but that approach begins to speak to the kinds of changes in the medical care delivery system necessary to address the problem of this prevalence. Interestingly enough, there's been another paper that shows that the ethnicity of the provider in terms of the patient's weight loss is only important in the case of white patients. It makes no difference in the term of in terms of African Americans in terms of weight loss. The other point here is that we now have 2 what I think are legitimate effectiveness trials in primary care, published in the same issue of the New England Journal 2 years ago. Both of these, as I said, involved care extenders. One of them involved an online weight loss strategy, which was as effective as a clinical strategy in achieving weight loss. Now, the lack of reimbursement is often cited as a barrier to treatment. Next slide, please. But there's been an interesting experiment underway with the Alliance for a Healthier Generation, which got about 10 different medical groups to agree to provide support for 4 visits with a nutritionist and 4 visits with a physician. And the general experience in these studies, as well as the experience of Blue Cross Blue Shield in North Carolina, has been that this benefit has not been utilized. So it begs the question of if reimbursement is available, why isn't it being used? And these are some of the reasons that the qualitative data that they provided. One is the lack of awareness by both providers and families of the availability of this benefit. A second barrier was varying requirements for documentation, which led to confusion about how to really enter people in this program. Pre-certification or enrollment requirements were another barrier. And interestingly enough, most of these programs required co-payments that varied from $25 to $75 for a visit. So that's a substantial expenditure for somebody who's seeking to lose weight. And finally, in terms of monitoring, there was very low use of BMI-specific diagnostic codes. So part of this lack of enrollment was that perhaps people couldn't really measure whether people were enrolled or not. 2 areas that I think are equally important but were not addressed in this study are the possibility of bias. And we know that bias is pervasive among medical providers. There was a paper just last week that showed among medical students at Wake Forest about 1/3 had overt anti-fat bias and about 40% had implicit anti-fat bias. And that extends over to providers and may be itself a barrier to care, that providers are as biased as the general population against obesity and therefore less likely to engage in care. Another potential explanation is the lack of self-efficacy on the part of physicians and other providers, that how to start a conversation about obesity, what kinds of areas to focus on may not be widely appreciated, and it's certainly not routinely taught in medical schools, nursing schools, or dietetics. Now, coming back to the next slide, the chronic care model, the other role that the medical system has that is very underutilized is support for environmental strategies. No one is more familiar with the need for environmental change than physicians, who recognize that obesity occurs in an environmental context, and simply staying within the walls of our clinic is not likely to be effective. But efforts at building advocacy among physicians are just now getting underway. There's a pediatrician in Rochester by the name of Jeff Kazarowski who is beginning to teach residents how to advocate for public health changes, and some of those have been in the area of obesity. But those efforts are really nascent. Now, in order to, the ideal model for obesity, which Kaiser Permanente is moving towards, is a complete integration of these two elements of the chronic care model. That is, integrating the efforts in the medical system with supports within the environmental system. And there's some interesting new approaches that begin to get at this. Next slide, please. One of these is baby-friendly hospitals. And next slide. As many of you know, the breastfeeding initiation among African American mothers is low, and the duration of breastfeeding among African American mothers is low. CDC is spending now about $10 million a year for the last 2 years to develop baby-friendly hospitals in the southeastern portion of the United States, which has the lowest rates of breastfeeding among African American mothers. And these are some of the areas that baby-friendly hospitals are addressing. That is the existence of a policy, early initiation of breastfeeding, skin-to-skin contact, rooming in, feeding cues, limited use of pacifiers, and breastfeeding support following discharge. And you can see that this is really an area in need of massive improvement. Less than 5% of hospitals in the United States are baby-friendly. Another area that didn't come out of the medical setting, but is one for which physicians and other healthcare professionals can reasonably advocate, came from the next slide, Child Obesity 180. And Chris Economos, who leads this effort, and Neil Nicole and I, and the organization, pulled together these various organizations which serve children out of school and focused on 3 strategies: drinking right, which means water instead of sugar drinks; snacking smart, which means fruits and vegetables instead of high caloric density snacks; and moving more, quality physical activity. The importance of this as a community level intervention is that this addresses millions of children out of school and large numbers of minorities. The challenge is to now disseminate these strategies from the CEO level down into the local level, and this is where healthcare professionals, I think, can have a major impact. Next slide. So there are a number of opportunities in medical settings. BMI is still not routinely measured in pediatric practice. Most recent paper that I've seen indicates that it's only measured about 50% of the time. Providers of all types are not taught appropriate terms to talk about body weight. Fatness, bulk, obesity are unacceptable terms to patients and to families, whereas weight, excess weight, and increased BMI are much more acceptable terms. It's important, particularly in African American populations, to address perceptions regarding the validity of BMI in those groups. It's true that there is more lean tissue than in African American populations than in Caucasian populations at the same weight. But when you get to a BMI of 30 or a BMI at the 95th percentile in children and adolescents, any weight in excess of that is body fat. But the BMI, at least in some centers, the experience is that the use of BMI derived largely from a white population is mistrusted as a measure of obesity in African American populations. We tend to think that the focus only on obesity is sufficient to engage patients, and we forget that many people don't understand that obesity is a marker for type 2 diabetes, and many families have had experience with blindness, chronic renal disease, and amputations as a consequence of type 2 diabetes. And we need to make sure, both at the patient level and in the public discourse, that obesity is seen as a health issue, not a cosmetic one. Another important strategy is to change care delivery and to align treatment with severity and reimbursement. In the adult population, about 40% of the costs are generated by 8% of the patients, obese patients. Those obese patients have a BMI above 35, and yet our care is generally one size fits all. We've already talked about innovative strategies for care delivery, and importantly, we need to begin by revising the curricula and defining competencies for health professionals at all levels, both with respect to what they should be doing in the area of prevention, as well as treatment, and include particularly attention to stigma and bias related to obesity, because it's clear that if we start early educating students in this regard, that they change their perspective on obesity from an individually based problem to one which has many more environmental determinants. And finally, next slide, please. The current educational system is still based on what we were learning in the last century, where the focus has been simply on competencies defined as scientific knowledge. That no longer holds because it's impossible for a student to acquire all of the knowledge that is exploding around us. And increasingly, we're going to need to define those competencies based on what the health needs of the population are and what the needs are of health systems. So things like training in behavior change, understanding how to work in teams, understanding and having the ability to link public health and clinical systems are going to be the kinds of credentials and the kind of training that we need to really address not just the problem of obesity, but more generally the other problems of chronic diseases. So I hope this sets the stage for the discussions that follow. Next slide, please. The first speaker is Deborah Burnet, who's a professor of medicine and pediatrics at the University of Chicago. She serves as the section chief for general internal medicine and is the vice chair for faculty development in the Department of Medicine at the University of Chicago. And her topic today is a Power Up After-School program to prevent obesity, largely among African American children. She'll be followed by Ryan Buchholz, who is a pediatrician here in town at Unity Healthcare, which sees a group of ethnically diverse immigrants, largely from Central America. So we're going to have African American and Hispanic perspective here. He has also just been named to the steering committee of the American Academy of Pediatrics Institute for a Healthy Childhood Weight. So, Deborah?